It's an honor and a pleasure to be here. It's really cool to see this kind of interdisciplinary team come together because epilepsy care and epilepsy surgery is really a team sport, right? It takes a village. And it's really important to kind of think about this all together, and it's awesome to have such a cool program. So thank you, Dave, Elizabeth, Dan, everybody, because it's really making us think about what we do on a daily basis and really thinking about the world in a different way, right? How do we fit into the social fabric? So I'm going to talk about survival in epilepsy and epilepsy care from the lens of a pediatric neurosurgeon. I'm also a health services researcher, but I'm going to try to kind of wrap up this morning, early morning session a little bit with this lens. So I have some disclosures. I'm a consultant for Jaguar Therapeutics, Encoded Therapeutics, and LivaNova. I will not be discussing novel surgical techniques using any of these. So the burden of epilepsy, as we heard, is that epilepsy is actually the most common neurologic condition in the world. And it affects low and middle income countries disproportionately. When you look at the US, I am so glad that Ahmed's and my numbers match up. The epilepsy costs that we know how to measure are about 60 billion annually, and that's just what we know how to measure right now. There's also the increased risk of premature death, right, in just kind of living with epilepsy, and that's just not from SUDEP, but that's from seizure-related accidents and suicide and other comorbidities. So there's a huge rationale for epilepsy surgery from a seizure control standpoint, from quality of life, cost to the system, cost to society standpoint. But from a pediatric epilepsy point of view, that there's really ongoing detrimental effects of the seizures themselves, of the anti-seizure medications, and really the effect on the developing nervous system, right? So if we can do surgery safely, and effectively, we can really improve quality of life and improve seizure outcomes, and really improve the potential and of what the child can achieve in terms of neurocognitive outcomes. When you look at mortality risks, especially in new onset childhood epilepsy, can be 5 to 10 times higher than the age-matched population. So there are many things that help us really think about the urgency, right, of getting through. How do you get through this gauntlet of multidisciplinary pediatric care for epilepsy to really screen for and get people to what we can do for early epilepsy surgery in kids? So in neurosurgery, we always think about the randomized controlled trial that showed that temporal lobe epilepsy works, right? That it clearly provided better seizure control rates than the medical therapy group. Now, we are 25 years later, and when you look at the number of epilepsy surgeries done in kids and adults, you'll see maybe the pure number increased a little bit, but it's really been quite stagnant, as Ahmed pointed out. But we know in general it's underutilized and catastrophically underutilized. So fewer than 1 in 3 kids who can benefit from epilepsy surgery, and estimates are actually getting to epilepsy surgery. And we know that disparities exist based on race, ethnicity, and insurance. So my group looked at this in a national database, looking at the effectiveness of medical versus surgical therapies in people with drug-resistant epilepsy. And this was using the Children's Hospital Association's FIS database. And we had 4,000 matched pairs in this cohort for medical versus surgical treatment. And we could show that healthcare utilization was reduced in the group that received epilepsy surgery. So this mirrors the adult literature that has come out of the great groups such as Cleveland Clinic and Emory, and also in the UK. So in a pediatric specific group across the US, people who received epilepsy surgery were having decreased healthcare utilization, fewer inpatient visits, ED visits, and also were on fewer anti-seizure medications. And we also noted that this effect of survival. So usually when you look at reported outcomes in epilepsy, we really talk a lot about seizure reduction, healthcare utilization, neurocognitive development, quality of life, but it's actually a little bit hard to get to survival, right? So we'll look at the Scandinavian studies, the European studies, and UK, and some in the States, but it's actually not very common to be able to have longitudinal follow-up like this beyond some epidemiology studies. So that's what my group set out to look at, which is using the FIS database that had longitudinal follow-up with, we were able to look at 10-year survival. So we looked at 3 cohorts, actually, for children who met the criteria for drug-resistant epilepsy. We looked at the anti-seizure medications only cohort, anti-seizure medications plus vagus nerve stimulation, and anti-seizure medications plus cranial epilepsy surgery. And we published this last year in Lancet Child and Adolescent Health, which when you compare these 3 cohorts and you look at 10-year survival, those who underwent cranial epilepsy surgery or vagus nerve stimulation had a higher survival rate than those who received medical treatment only. So the effect is really not subtle when you looked at that survival curve. So let's see, this is showing you the cohort definition. And I'll show you the survival curve again, but really this spanned over 18,000 patients. So we really had quite good statistical power. And this is the table 1 of the demographics, how it played out. And there are some differences in the cohorts, and we'll go back to this. But really the big point of the study here is that when you look at surgical therapies, those who had epilepsy surgery had a probability of survival beyond 10 years of 98%. Those who had VNS had a probability of being alive at 10 years of 92%, and then those with medical therapy, 89%, and this was significant. So if you look at it a different way, compared to the medication-only cohort, kids with drug-resistant epilepsy had their risk of overall death reduced by 35% in the VNS cohort or 83% in the cranial epilepsy cohort. So in looking at what this means, if you look at the survival advantage of the cranial epilepsy surgery cohort, we have this opportunity to prevent deaths in epilepsy with treatments that we have, right? Epilepsy surgery. And while if this were a neurosurgery meeting, we would all be here arguing, we got to cut this way, we got to cut this way. No, we got to stick in lasers. No, we got to do endoscopes. We got to do implants. Fundamentally, if we have good patient selection and we're getting to patients who can benefit from care, from multidisciplinary epilepsy surgery workup or getting the surgery, we actually can prevent a considerable number of deaths. And if you actually just look at pure numbers, the number of deaths we can prevent is probably bigger than the Back to Sleep campaign for sudden infant death syndrome and fire safety and fire prevention. So we know epilepsy surgery is underutilized. We know that there's disparities in access to care. So how do we pave this road to epilepsy surgery altogether? So I said we'd go back to table 1, right? Which is when you look at actually who got epilepsy surgery or vagus nerve stimulation and who was on medical therapy, those who receive intervention surgically are more likely to be non-Hispanic white or privately insured, right? This is not surprising to this group. This has been shown in every single study in epilepsy surgery across North America for 30 years. So, to me, this is more than neurosurgery, right? In order to have good outcomes, of course, we need timely, appropriate referral, good patient selection. But what happens before getting to surgical evaluation and care, and how do I identify and lower barriers? So we've been looking at this for some time. I showed you kind of the national database studies that we did. And sometimes people will say, well, that's like everybody, right? That's other people. That's not us. So when we worked all together at Texas Children's, we actually looked at this and just said, let's look at us. So Dave Clark took up the challenge to actually say, how are we doing? So we looked at 98 patients, same diagnosis, cortical dysplasia, did a retrospective chart review and looked at time between diagnosis and surgery and found actually disparities by distance to the hospital from where families lived, insurance status, and race. So when you look at it, patients of non-white race actually had a longer duration of epilepsy diagnosed in the chart before receiving epilepsy surgery for the same diagnosis. And this was not subtle. The difference was over 3 years. And they were actually more likely on Medicaid and actually traveled a shorter distance to the hospital, right? How could that be? We actually lived in Houston, closer to the hospital. So, and that's it under our own roof, right? So this is a multifactorial problem and one that we need to work on all together. And really that study and all studies that we've done to date, we don't actually know what is the one thing or the many things, right? And like Priscilla talked about, there's so many socioeconomic, cultural, and economic and so many other barriers. So when you look at social determinants of health and how they contribute to drug-resistant epilepsy care and more, we really need to look at this all together and come at it in different ways. So this is a story that's continuing to be written. I'd like to share that this is another way that my team is looking at this. We're looking at how do we align outcomes that matter to families. And of course, survival, economics, everything matters, right? So, but this is the crux of our PCORI-sponsored study that's multi-center, and we partnered with the Lennox-Gastaut Syndrome Foundation. Many of you in this room are involved in this study with our different centers. But when we looked at comparative effectiveness of palliative epilepsy surgery with anti-seizure medications for LGS, we saw that there is equipoise in the literature for medication versus palliative surgery for things that we know how to measure, right? So, healthcare utilization afterwards. And this is our core team, so multidisciplinary. And we're looking at comparative effectiveness between medical and surgical therapy for things that I showed you that we know how to measure, right, which is healthcare utilization. But then when we worked with the LGS Foundation, they said, wait a minute, we really, really care about expressive communication, behavior, and quality of life, which is things that I'm really bad at measuring in insurance and medical records, right? So we're partnering together between 7 sites to actually do qualitative surveys with families and patients. So we'll also look at real-world utilization and look at how care is actually being delivered. So this is still kind of in progress. These are all the sites involved. Part of this is actually we're developing a computable phenotype to actually look at the ICD-9 code, because as you all know, epilepsy care is actually really messy to look at by coding because of the variations that there can be in ICD-9 and 10 coding. So we're actually looking at medical records and trying to define how to look at Lennox-Gastaut syndrome for now and for future studies. And then what matters to families. So we're looking at how to measure behavior, communication, and quality of life with the validated surveys and seeing where they fall short. So this is our time frame and how we can actually keep on going. And we just got a supplement grant from PCORI to measure indirect costs of care with families. So this is something that we're really bad at looking at, right? How much did you pay for parking? Did you have to take days off work? But there's actually so much more to that, right? So if you actually work with one patient, right, one mom, this is kind of her support map, right? For, all of this, right? It's social isolation. It's the finances. It's the bills. It's worrying about everybody else. It's the siblings. It's the elders. How am I going to hold down a job? And when you look at the impact on families with LGS families, like Dr. Ko has been part of generating this. Look at the family impact, right? Worried about finances, right? It's like an emotional roller coaster. And when you look at the National Child Health Survey that's with the U.S. Census, 1 in 4 families with children with epilepsy report having one adult have to reduce work hours or quit their jobs. So, and then families with Dravet syndrome report that there's about 47 missed work days per year taking care of a child with Dravet syndrome. So really, I would say, we're part of a system that could really help families and actually keep them in the workforce and return them to work so that we can actually be all part of a social fabric. So what we do is actually beyond helping the child with epilepsy, it's helping the parents, the family, and actually the economy and the world at large. So I'll finish with the last few slides for food for thought, which is Dr. Boob talked about the WHA resolution for global epilepsy acceleration for coordinated care. We've been able to do some of this, right? Dr. Tyler Kabara said, so what do we do on an individual level? And we realized from Lurie Children's we can have an impact on programs around the world. So we work with a team in Uganda, and we have the same equipment. We're able to actually now develop capacity for doing EEGs and identifying patients with lesional epilepsy, and actually developing an epilepsy surgery team to be able to help with changing the course of epilepsy there. So we have bidirectional input. We do trips to go there. We've actually taught EEG on Zoom. And we actually have regular epilepsy surgery conference in a multidisciplinary way on a weekly basis. We've been able to do epilepsy surgeries there to the point where the local team is now independent with lesional epilepsies. They save up some of the other surgeries that they're less familiar with so that we can actually train and develop skill and knowledge together. So it's just an example. Hemispherectomy patient, lesional. This patient didn't go to school anymore, right, because of the stigma, because of the falls, because they were just kicked out of school for the seizures. But we're able to do this safely, no blood transfusion, and doing really well. So I would submit to you that this is a scalable model for how we can impact care of patients and families and communities around the world. And that's kind of how we seek to do better together here for our patients, for families who never even come through our doors in a public health way, and also in a global health way, that we really can use technologies and ways to bring the world closer together and elevate health together. So I'd invite you to think about this in advocacy altogether. And you can scan this for references for some of the things I've talked about, and please reach out so that we can work together.
So an amazing session so far. I'll ask the speakers to come up and again, come to the mic if you have any questions.
Hey, Dave. So this one's for Ahmed. So, the FDA has, for several years now, if you develop a new device for anything, if you have a new device to, non-invasively crush a kidney stone, you have to not only prove it works and it's safe, but they have economics as part of their evaluation. And so both the pivotal DBS studies for epilepsy in the U.S. And the NeuroPace, the responsive, had economics built into them. And in the studies, neither one of them showed an economic benefit. So how do you, I've seen the papers come out since then, but I always struggle with how do I kind of, say, okay, those prospective studies couldn't show it. The retrospective seemed to indicate it for those devices. I think for VNS, the data is so overwhelming, it's unquestionable for that. But and I don't have an MBA, so explain it to me.
Well, they didn't teach us that in the MBA, but so for the DBS and for the RNS, it was actually built on the efficacy and the tolerability. Because of the need for the patient population, as long as it's not, and if I recall correctly, it's not more than 20% extra cost, that's how it got approved. So it's not just that it has to save money, it cannot be more than 20% above the current care. And that's in a smaller pivotal study. It's not hard to show that less than 20% added cost, but when you start applying it and when you start, I'm going to call it non-regulated studies and non-regulated utilization of resources and investigation, that's when that 20% can easily be 120%. So I don't have an exact answer to it. I know that with that 20%, those devices were able to meet that under 20%. That's how they got approved. But past that, it's a real world scenario where we know that it's a lot higher than that.
Thanks. Suki?
Oh, what a strong beginning. I really appreciate all the talks you had today. So we are thinking globally. I have a specific question for Priscilla. You mentioned how quality of life in children with epilepsy were measured by parents' perspective, and I became aware of the discrepancy between the quality of life measurement by parents versus young adults. And I think it was Amberg who pointed out to me, the parents who care for the young adults thought that they were depressed, anxious, and doing terribly, while the young adults thought they were doing okay. And so I just want you to comment more on that discrepancy we had found.
Yeah, I think it's a complicated question to answer, but I think you're definitely right that there are differences between parent and self ratings. In the parent group, we also have a broader range of patients, right? So these are the patients who have more significant deficits, who are never going to be able to rate their own quality of life. Whereas the adult group, these are individuals who are able to rate how they're doing. And so I think those cognitive factors and their self-perception and how they're able to function independently becomes more important. Whereas I think there is a reflection of caregiver stress and what they're seeing in the child that is highlighted in those parent ratings. And also, of course, I think some individuals might not have an accurate perception. So there's also that discrepancy as well. But unless we're able to compare both ratings within the same study, it's hard to directly make those conclusions.
Hi, thank you very much for the enlightening talks. My question is for Sandi. Sandi, you mentioned like the discrepancy in time from the diagnosis to surgery, particularly with the travel time I'm interested in. So is it like what you saw, was it because of the families, because they live closer by, they were not interested in early surgery? And was it like because those who traveling far away were more interested in completing it done, or were there other factors?
We don't know yet, right? So that's the next study. We actually just put in a community engaged participatory research grant to actually work with the families and really get into the nitty gritty, right? Because there's so many things that we talk about, right, for underutilization of surgery and the healthcare disparities. There are papers and kind of narratives on trust, access to care, financials, health literacy, language concordance, right? But there's actually very few studies that study that from a lived experience point of view. But when you look at our own practices, right? So if I just kind of reflect on certain things, which is There are very well-educated families who have done all their research and come and say, okay, I want my workup, diagnosis, and surgery now. I'm going to check into a hotel and we're going to coordinate all the care, right? And we have epilepsy surgery program coordinators that do this, right? So, and then if you contrast that to, say, a family with a single parent or parents who are holding down multiple jobs and actually have other kids in the family and they live close by, and you say, you know what, your MRI slot got canceled today. We're going to reschedule you. And they say, okay, thank you. Whatever you say, doc, I'll come when you call. We'll make it work. And that could be 2 months from now, 3 months from now, right? And then we put them through a gauntlet of MRI, video EEG, PET, and neuropsych testing and all that. All this for the privilege of being considered for epilepsy surgery and then actually having to take more time away from work, right? So if you actually map that all out, that amounts to at least 2 to 3 weeks off work to get to the surgery standpoint. And then when we talk about foregone family employment and the indirect costs that we're not good at measuring yet, that actually, when I put all that together in writing the indirect costs of care and caregiver burden grant, I realized it changed my worldview, actually, of epilepsy surgery and why so few people are getting it and only white, well-insured people are. It's because the families can afford to do that and actually get it quickly, right? So we need to kind of think about this all together for. It's going to be very difficult to try to, solve all of the social situations and issues of the world to be able to help kids with epilepsy. But I think we need to go there, right? And that's the only way that we're going to be able to help more kids and families is how to embed social supports at the right times and in the ways that we can in a team-based fashion to be able to do this.
Yeah, I just said before the final 2 questions, the one thing that we don't include quite often is the cultural sensitivity and historical potential healthcare problems related to societies. And I think we're missing a huge slot of the problem if we do not include that. Yeah, I'm sorry, Jorge, and then TK.
Thank you, Dave. Excellent talks. This is for Sandi. I have a question for you, Sandi. We are doing something similar to what you're doing in Uganda, in Central America. So we were partnering with a center in Texas to go and create epilepsy surgery program. It took us many years. The main problem we had was infrastructure in the public hospital. So we created a hybrid with public hospitals. The surgeons that were coming from here didn't feel comfortable to operate in something. How did you overcome the infrastructure problem? So if not, it would take many years to build even just a program for just lesional.
So this was actually a very special scenario where the partners that we work with in Uganda are in this oasis of pediatric neurosurgery where Ben Worf at Cure Uganda had developed endoscopic third ventriculostomy and choroid plexus cauterization and showed that was a very viable and good way of treating pediatric hydrocephalus in sub-Saharan Africa. And there's a lot more of that in sub-Saharan Africa because of the high rates of spina bifida and perinatal infections. So because of that, that became a mecca of learning about pediatric hydrocephalus and how to do the ETV CPC surgery. So the world actually went there to learn how to use this endoscope and do it very well. So it's a story of reverse innovation, which we call reverse innovation then, which now we call globalization, which is there has to be two-way streets, and many of them, for us to learn from each other. But that center is actually where we built this pediatric epilepsy surgery program. So I've been operating with these colleagues for 13 years. They're very good surgeons, like Dan Curry said. So really, they can take out a brain tumor, they can do spina bifida, they can do hydrocephalus, but they actually said, we're really good at preventing death now. We're really good at treating the acute things that are obvious in front of us, but our patients are living longer. When they come back in follow-up, we realize they have epilepsy, right? They have spasticity. And there's surgical treatments for this, but that wasn't really part of our training in Africa, and that's really not part of our training in setting up this program. So can you do it with us? So that only left a couple of gaps, right? How to use the EEG machine, how to identify patients who can benefit, and then doing the surgery. But since they're good surgeons already, that part was actually the easy part.
Thanks. So we'll go an extra 5 before, so I'll have a question from you and then you, because it's quite important. And then we'll adjust.
So this is really for all of you. You talked about the families who are right there and the problems, but I think one of the things that we have also seen, and I am blessed by having a very diverse team, and I am fascinated by the Spanish-speaking family that comes in who hasn't told any of us about the fact that she no longer has a place to live and she's living in the hospital, and it's one of our MAs who happens to have this conversation and comes back to us and says, hey, by the way, they're homeless and they're undocumented. What are we going to do? Or my other families who connect with one of my PAs and doesn't connect with the rest of us in that very personal way, where we learn about all of those kind of cultural challenges. And so I think one of the things that we are all driven to do is to make sure that our teams have a diversity that matches our patient population. Because the first time a student, a learner, said to me, this is the first time in my life I've seen people who look like me who want to do what I want to do. And I had to stop and scratch my head. Because honestly, coming up in neurosurgery when I did, nobody looked like me. But it also really sort of made me think that for our patients, being able to make that connection sometimes really helps if the person they're connecting with looks like they do.
Yeah.
I just wanted to put a plug in for that.
Sure. Awesome. This was phenomenal. A really cool start. We're going to take about 10 minutes. We'll run a little late, but I think these are all 5 minutes, 7 minutes. We're bargaining. All right. Anyway, take a break and come back in as soon as possible.